Hello, everyone. My name is Ryan, and I am here today on behalf of the marketing team with School Health. I'd like to thank you for joining us today and participating in our webinar as we welcome back Dr. Joseph Bart for part 2 of this webinar series that is focused on life-saving tools and strategies for emergency situations. You may remember in part 1, Dr. Bart discussed the challenges around rescuer engagement and current barriers to accessing patient care. In this part 2 follow-up, he will discuss the strategy of response and help you think about how your current emergency plan would hold up to the stress of a real event. Before we get started with Dr. Bart, I'd like to thank our friends at Zoll Medical for supporting us in bringing you today's presentation. During today's presentation, we'll be selecting the names of 2 lucky winners from our list of live attendees. The winners will each receive a Mobilize Interactive Trauma Compact Kit, and we will select the winners after Dr. Bart's presentation before we move to the question and answer portion of today's presentation. We'll turn the time over to Dr. Bart here very quickly, but I want to review a few quick things first about today's presentation. First, we will not be taking audio questions, but you can submit your questions through the questions interface in GoToWebinar. You can submit questions anytime during the presentation, and we will take about 10 to 15 minutes at the end of the presentation to answer your questions. Of course, this webinar will be recorded, and a link to it will be emailed to you for future playback. And everyone who attends today's webinar will also be receiving a certificate of attendance for joining us today, and you should expect to receive that by email later on this afternoon. Lastly, if you are having technical difficulties with the audio or visual portion of today's webinar, please contact GoToWebinar directly at 855-352-9003. And that number again for GoToWebinar is 855-352-9003. And now I will turn the time over to Dr. Bart.
Thank you very much, Ryan. All right, so welcome back. If we haven't met before, I'm Joe Bart. So we're going to talk about part 2 of this tools for the job. We're talking strategy, and again, we're trying to integrate lay rescuers into your practices. Again, I'm Joe Bart. I'm a practicing emergency physician in the Buffalo, New York area. Just a quick disclosure here: I'm an original contributor and medical director for the Mobilized Rescue Systems and a consultant with Zoll Medical. All right, so let's start with this. We want some objectives for the day. All right, we want to talk about review. All right, so review of the gap. If you participated in part 1 here, but even if you didn't, I think we can get enough where we can get everybody on the same page here. We're going to review this gap of response and pre-hospital environment and talk about really what that is, because it's kind of the foundation to the discussion as we dip a little more into lay rescuers in their need for response strategies. After that, we are going to talk about our strategy and response and how your preparations are if you were to have an actual emergency. Who's part of your team? What kind of equipment do they have? Where is it located? Where are they coming from? Maybe it's just a couple of strategy things for you to be able to take back and integrate those into your emergency action plan. Excuse me. Tools for the responder. I want to discuss the mobilized trauma kits, maybe some real life emergency exercises. We want also to empower a system of respondents to augment your emergency action plan. Again, we're going to talk about the integration of the emergency responders and the lay rescuers into the gap itself. And then we can put it to the test. All right, some take-home tips so that we can actually take something out of this and hopefully integrate that into your next emergency action plan meeting. All right, so how can bystanders make a difference for us? Oh, one sec. Oh, I just lost it. Sorry. Of course, this is how it works. One second, everybody. My bad there. All right, now we're back in. So let's talk about the response gap and how bystanders can make a difference. The fundamental of—
Dr. Bart, I'm sorry to interrupt. We're still not seeing your slides.
You're not? Oh, no. This is technology, right? Are we back?
There we go. Looks
All
great.
right, let me back up one here. Just talk about the response gap. Sorry about that, everybody. The fundamental of a successful rescuer is going to start with the initiation of this response plan. And the core of that phase, I believe, is the bystander. So what exactly is the problem? Again, this is a refresher, so bear with me for a second. We're going to talk about the gap and what is this gap itself. Picture yourself where an emergency happens. So that emergency medical location, wherever that place is going to require a 911 call, okay? So the patient is sick, the patient is injured, whatever the circumstances are, somebody places a 911 call, okay. After that, it goes into a 911 dispatch center. From the dispatch center, it's going to go to emergency services. In this case, we're seeking an ambulance. All right. We're going to try to define the times because I think times are important for individuals. Certainly, we look at them as an emergency medicine physician doing EMS medical direction. Times are very important to us. It's part of the analytics that help guide, is our system healthy or not. We really can't define the amount of time it's going to take for somebody to recognize there's a problem to call 911, but arguably everybody has a cell phone. So let's say that time is probably pretty quick. Then from 911 into the in the dispatch center itself, sometimes you get bounced around through some towers. If it's a busy day, let's just say 30 to 60 seconds, okay? After that, from your dispatch center, depending on where you are and where the ambulance is coming, there's somewhere between 30 seconds and maybe 4 minutes, 4+ minutes to get the right responders to where they're in an ambulance or at least notified of the call with the correct address to get the responder there. This over here is the gap. So pay close attention to this idea. This dotted line that says to get the ambulance, ultimately the paid or volunteer professional rescuers to get them to the emergency location where the patient is requiring treatment. All right, so you summon them. What do we get them there? So the average times for this are about 7 to 9 minutes in an urban area, 10 to 15 minutes in a suburban area, and can be 20+ minutes in a rural area. So it is quite dependent on where you are in relation to where emergency services may station themselves. All right, so let's put this gap on a timeline. I like timelines. In response, we say the ambulance is all the way to the left, okay? The patient is all the way to the right. Now, everything worked. You made a phone call, somebody made a phone call, we got through the response thing in it. And honestly, if you've ever been frustrated with that, if you've ever had to make a 911 call before and they start immediately with, what is your address or what is your contact information? It's not that they don't want to hear your story, but be patient with that process. And I'm giving you this information so that you can build this strategy into your emergency response plan to understand that the very first thing that they're going to ask you for is where are you and how do I get a hold of you if this call is disconnected. So just keep that as page 1. Let's talk about this gap. So again, the ambulance all the way to the left, we want to get them to the patient care. This is an average of about 9 minutes, right? We took the urban, the rural, the suburban, let's just call it an average of 9 minutes, okay? All right, so let's talk about tools for response. Again, let's use what works and the strategies of what worked for us in the past. AEDs are really successful. I think anybody's going to have a tough time to argue that AEDs can't actually do the job for us. AEDs, I think, are a wonderfully successful program and the impetus of the jump off to where lay rescuers can really do their best. Think of what an AED does for you now. This is a particular example in front of you shows that there's a screen. It talks to you. There's only a couple of buttons to use. You essentially put pads on a patient. It does all of the background information for you. It analyzes, it shocks. Who's the most important person to engage in that situation? I think it's a lay rescuer. So you might ask yourself, how else can we engage the lay rescuer to help? So why the hesitation? And I think we talked about this before, but let me also remind that there's probably a lot of professional rescuers that have joined our webinar today. Whether your training is in nursing or emergency medical services, or you've just taken CPR first aid courses. And I think that that is wonderful. All that stuff makes a difference. But when we talk about lay rescuer engagement, I'm saying that you're the hub, they're the spokes. So why not be able to use the lay rescuers at these points where there may be an opportunity, wherever a patient is sick or injured, to start patient care ahead of professional rescuers getting there? That's the entire point of what we're trying to discuss. But the hesitation themselves about why bystanders don't get engaged. And I had to say, the first time that I looked at this, I said, it's got to be the blood and the guts and the gore and all that stuff where it's like, that seems gross. Like my younger brother has no ability to change even a Band-Aid on one of his kids. It's just some people are not in tune with this. And I said, let's really dig into this. So if you look at the research for this, bystanders aren't getting engaged because they don't know what to do. All right, that seems reasonable. Or perhaps they're afraid they're going to do more damage than good. The other part of this is, well, what if I get sued? What about the outcome if it's bad or otherwise? I helped this person, it didn't work out right. I didn't really know what to do in the first place. I don't have the equipment or the training, so I'm just going to choose to just watch. And we're usually the benefactors of situations like that, because we can review these things from the multiple cell phones that were taken out to take pictures and videos of scenes where perhaps somebody that was going to get engaged would have done so had we provided them the tools to do that instead. So let's talk about the technology. Can we use technology to engage the lay rescuer and empower the medical team? All right, so for mobilized purposes, the mobilized rescue system, let's talk about this. It's equipment for rescuers, all right? A solution to the gap problem. That was the whole basis of Mobilize when it was started, to say, is there some stuff that we can do that allows a lay rescuer to become engaged, become empowered, and become confident to be part of an emergency action plan? All right, when we talk about the algorithm to use that, it's a solution to the gap so that the lay rescuer can get engaged and start doing the right stuff at the right times so that they're actually helping. So again, what is Mobilize? Let's talk about this. Your emergency action plan, and we'll get back to the Mobilize. I'm not just skipping right over that. Let's talk about your emergency action plans. I want to put you in the right frame here. What does your emergency action plan need to have? So the sequence and the requirements of emergency response. What happens? Well, somebody has to discover that there's an emergency in the first place. Maybe you're not part of that, but you certainly are going to be a responder to that. So you're reactionary to number one. The second is to call 911. Very important. Address, patient information, condition. Some of you may be in large buildings, on large campuses. Are your doors numbered? Are your driveways numbered? Do you know exactly who you are on the campus? Because we talked about an ambulance coming in 9 minutes, but that's 9 minutes to your physical address where they were dispatched to. Does that mean it's 9 minutes to the actual patient? Be wonderful if it is. Is there something else we can do? I suggest you you develop a system in which there's a waiver. You send somebody to the driver or the driveway that you directed EMS to go to, because as it bumps through multiple dispatch centers and 911 centers, the actual attendants of the ambulance may not be getting that information in the first place. I did that job. I can tell you, you show up to locations and there's 100 people standing around, you don't really know where to go. Having a dedicated waiver to bring them in where the patient is or direct them, big win. From your team perspective of responders, who's notified as part of the plan and how are they notified? Is this a call all over the speaker? Probably not. We're not going to usually do it like that, but is it radios? Is it cell phones? There's apps that are the part of this, but we certainly have to be able to notify individuals that there is an emergency happening on your campus to activate the system. And then we have to get to a patient assessment. Like, we brought all of our stuff and our people to where there's a patient who's sick or injured or ill. Now what? Now what are we going to do? So there has to be some assessment. Now training is huge. If we can train everybody to do this type of a job, I think you're a very safe organization. Training exhausts, unfortunately, over time. If we're not able to use that on a consistent basis, and it's not your job necessarily to have formal training on that, then you start interjecting little holes. We're going to poke holes into people's plans, and all of a sudden their confidence goes away. And what happens? They decide that they don't want to respond anymore. They don't want to be part of the action plan because their confidence isn't there. So the empowerment needs to be part of that. And then let's just chat about the medical care. So we're there. What is the priority? Where's the action plan say that we're going to assess somebody based off of this strategy? Again, if training is there and you're the trained rescuer, this doesn't necessarily apply to you. You just go ahead and take over at this point. Do what you need to do what you were trained to do, and start treating patients. So let's put up our gap here again. I just went over this. All right, gap 9 to 12 minutes, perfect. So in between this 9 to 12 minutes, what are some time-sensitive medical conditions in which we can engage the lay rescuer or people in your emergency action plan that are willing responders, by the way, but they maybe just don't have the tools and the job and the training to do everything they need to do. So 911 has been activated, check. That's a very important step. So bleeding, unconsciousness, overdose, difficulty breathing are not just the top end areas, but these are also very commonly called 911 calls in the first place, for emergency services to becoming, regardless of the circumstance. But if we talk about them also in a timeline, these are some of the most time sensitive conditions in which that 9 to 12 minute gap is vital now, because the ambulance is on its way, but they're not there yet. And there may be something that we need to do in between. So I want you to start with the initial list of focusing on these 4 things: bleeding, unconscious, overdose, and then difficulty breathing. Again, some tools here. We've got AEDs. Everybody has the AED out there. At least I hope you don't. If you don't have an AED, your immediate action here is to call your school health representative and rectify that problem. There's really no excuse for that, to be honest. After that, what about rescue kits? What about first aid? Is it a convenient white box that sits there or something that has Band-Aids on it? Because I'm not talking about Band-Aids kits when I'm talking about major bleeding, unconsciousness, overdose, and difficulty breathing. There may be some stuff that's in a response kit, but I'm talking one step beyond that. One step to be able to fill the gap of analysis, patient assessment, and medical treatment in the 9 to 12 minute time period in which EMS is on their way. Let me give you again, these are some review strategies from part 1, but I think they're important. If you want an algorithm for this, I love algorithms and I love timelines. If you're watching this, you know these things already. March E, massive bleeding is your #1 priority. And March E was adapted from trauma emergency casualty care. There's a little website down at the bottom if you want to get important information off of that. Massive bleeding is your #1 priority. And again, your #1 priority from the perspective of where do we need to engage lay rescuers and your emergency responders for campus and office-based emergencies, and really emergencies everywhere. Airway, next example. Respiratory concerns. This is circulation, hypothermia, head injury, and then there's everything else. Everything else are like minor burns, maybe some envenomations if that's part of the country that you're at. Broken bones are a big one. Very few circumstances I can tell you that a broken bone ends up being the most significant form of mortality in the first 9 to 12 minutes. If there's multiple broken bones and there's everything going on, then I can understand that's part of the picture, but that's usually not the major reason why we have catastrophe while we're waiting for EMS to arrive. Massive bleeding and airways certainly are. All right, so here's your Marchi algorithm again. I like timelines. Things that can kill you quickly, all the way to the left. That's the it's in red, sticks straight out to you. Then all the way to the right is like this delayed type emergencies. And I'm not discounting that a broken ankle is not an emergency because the person's not ambulatory. You need an ambulance to get them to a hospital for treatment. It is still an emergency. It's just a little bit lower priority for what we're trying to engage today. Here's my timeline. 0 to 5 minute problem, 5 to 8 minute problem, 8 to 10 minute problem, and then a 10+ minute problem or so. So when you look at this in particular, you might be able to already tell yourself, what are the major types of medical emergencies that we need to be prepared for, even if our ambulance service and our emergency services functions perfectly? You make a call to 911. Again, go back to your gap. You make a call to 911. It goes through dispatch center. You get an ambulance there. They're on their way 9 minutes later. What about this algorithm requires us to be prepared to intervene within 9 minutes? This is when we talk about engagement in the lane rescuer. Who can we get to be involved there? The professional rescuers are on their way. Somebody made a 911 call. That means they're there. Somebody else might be even closer than that. So how do we get the gear and what do we prioritize? Again, this is the target for medical emergencies with lay rescuers, is the M, the A, and the R. Massive bleeding, airway issues, respiratory concerns, that includes cardiac arrest management as well, unconscious, overdoses, kind of the things I pointed out in the first graph there. So again, all the way to the left, 0 to 5 minute problems, 5 to 8 minute problems. I'm not saying the other stuff is not important. And I think strategies and medical equipment and training to intervene on those help with good patient care, no doubt. If we're putting the patient care in the center of it, we're still doing good stuff for them. However, the most time-sensitive medical conditions in which we can potentially intervene and make substantial differences before EMS get there are these categorical responses of massive bleeding, airway, and respiratory concerns. Are you awake? Did I get you? I'm gonna tap on this thing here. No, you did not just prepare to dive in your submarine. You have an emergency activation. All right, so let's go at it. Wherever you are, you just got woken up, you were drinking your coffee, you were kind of half paying attention to this webinar. Whatever the case is, hey, it's cool. But it's 9:37 in the morning now, and there's a report of a severe laceration in the bathroom. The bleeding is not controlled. What's your job? Are you part of this plan? How are you notified? Are you going to go get some stuff? Start putting yourself in the mind frame of wherever you exist tomorrow morning at 9:37 a.m. and this happens. All right, you decide to get up and go. All right, 9:39, you arrive and you help place your gloved hand on the laceration. What are you doing next? I'm just going to pause for effect. to see, like, what are you doing next? What is the plan? In your institution, who's coming next? Is there somebody coming behind you? Did you call 911? Is there somebody else calling 911? You have gloved hand on what potentially could be a major laceration. You decided to assist. Believe me, you're engaged. So is everybody else that's going to come along and help with you, but do you have the training and equipment and knowledge to actually make a difference right now? If you're still with me, I'm guessing you do. All right, so 941, I'm going to insert mobilize. 941 mobilize arrives, and you get a bit more information here because the concept of mobilize is going to help you to make the best possible medical decisions to help the patient under the time-sensitive medical conditions we talked about, with Marchi as a good start. So you have a 54-year-old male who's a maintenance contractor who was installing a mirror that fell, then broke, and lacerated his forearm. There's a deep laceration with exposed muscle and tendon with significant pooling of blood. I skipped the picture, sorry. He's alert, speaking in full sentences, and clearly in pain and panicking at the loss of blood. I get that. So here's mobilize, and where mobilize could help you there. And if you already thought of what you wanted to do because you have the training to do that, then just follow along. If you're a little bit lost and think you might be panicking with the patient, let me show you what we can do for you. So here's mobilize. This starts on my phone. It says, take a deep breath. We're going to help you. All right, so hit the start button. Most importantly, we're calling 911. All right, this is just a reminder. If it hasn't been called, we're going to have you call, and then put your gloves on. You already put a gloved hand on this patient here, but make sure we got 2 gloves, and then it's actually safe to treat your patient where you currently are. All right, first question, is the patient bleeding badly? And you're like, I'm not really sure what that means. So there's a little button on the center that says, what is bleeding badly? It says, when it's uncontrollably coming out of a wound. All right, so you look back at this and go, yep, check, that's the problem. So I hit yes. And then I touch the area that's bleeding bad, right upper extremity. I'm going to touch that little button that's there, and it says, okay, locate the tourniquet. It's labeled A1. I find that tourniquet that's in the kit, and I hit OK. And now we're going to start walking through some steps of a tourniquet. If you've never used it before, hey, that's okay. You're going to get the concept here with step 1 of just open it up and slip it over their hand and wrist. Step 2, we're going to place it high up onto the extremity there. You can see it's even well above the wound. And then we're going to pull to remove any slack, just like a belt. And our next step, if we hit next, is twist until the bleeding stops. Patient may feel pain for this. I'm going to say they will feel pain for this. Tuck the black rod into the black triangle and do not remove the tourniquet. And then hit next. So did bleeding stop for the wound? Let's just say, well, what's life without whimsy? Let's say no. So prepare to tighten the tourniquet. Okay. So now it's going to say unlock the metal rod from the triangle. Pull tight to remove any slack. And we're going to twist that rod again until the patient feels a lot of pain, likely, but certainly until the bleeding stops. That's our management step. And we're going to tuck that black rod right back into the triangle here and do not remove that tourniquet. All right, we will pause for a moment here. How did you do? I gave you the scenario. I told you were there. You had a gloved hand on the patient. What choices did you make? And how fast did it take you to potentially do that? The panic portion of this is real. As the patient continues to panic, their blood pressure goes up, their heart rate goes up, and guess what happens to blood flow? It increases. Guess what happens to blood flow coming out of a major wound? It comes out faster. So there is time sensitivity in these conditions. Whether this was a major artery or not, well, we didn't really talk about that. And honestly, I didn't ask you to investigate that. And mobilize won't either. Your subjectivity behind saying this was a major blood loss, what do we do to control it? Well, we control it. And we put a tourniquet on somebody. So the medicine, and the reference of medical care has already been thought of for you. The job is follow the instructions. Give the device the information and follow the instructions. So if you were able to follow along and use those couple steps to be able to put on a tourniquet, recognize it wasn't really doing a right job, because the biggest failure of tourniquets, honestly, is that we don't put them on tight enough to start with. We don't pull the slack out of them. We don't really twist them down because they hurt. Nobody wants them on. So the biggest point of failure generally with tourniquets is we just didn't put them on tight enough. So the reminder step here, number 1, is let's just go ahead and tighten that just a little bit more and see if we can get the job done. All right, so the tourniquet was applied. There's still heavy bleeding. All right, so there's still more bleeding from this wound itself, but it seems like it's slowed down. Let's get back into mobilize. So did the bleeding from this wound stop? I'm gonna say no. All right, so it wants us to locate the next tourniquet labeled tourniquet A1. And that pause was on me, not on the device. All right, so we're going to locate a second tourniquet above the first one. We're going to place that well above it and try to do the same thing to cut off more blood supply. If you didn't think about that step, that is the next step when you're using tourniquets, is to take a second one, do the same steps to place it above the first tourniquet that exists there, higher up on the limb if that's possible. And then again, we're going to pull tight. We're going to remove some slack, twist the rod until the bleeding stops. Again, the patient is going to feel some pain over this. And then again, we're going to tuck the black rod back in the black triangle. And tourniquets are one of those things too that you should at least put your hands on to understand the value of what a tourniquet does for you. So did the bleeding stop? For the time being, we're going to pause that again, but good job. Bad bleeding from the wound has stopped. So that major hemorrhage that you saw coming out of that big forearm wound has stopped. Now there's going to be some residual bleeding around a wound. I described it as a big open gaping wound, but for the most part, that massive hemorrhage has stopped. So you plug the hole. Great job. So the ambulance is coming. You might even be able to hear the sirens or get a radio update of like, we think the ambulance has arrived, but the fact is they're not standing there next to you yet. So they're not there. What do you do next? So again, pause for effect. What would you do next? Is there bandages that you would use? Do you use gauze? Do you wound pack? Sort of what is your objective here? So if we ask mobilize, what do we think we should do here again? Did the bleeding from this wound stop? Let's just say yes. All right. And now it's going to say, are they bleeding anywhere else? Again, the machine doesn't know this. So if they're not, you say no. Are they talking to you? That's an important point for me because if they're talking to you, they're awake and they're alert. Now, if anybody bleeding bad, and I selected they are talking to me, by the way. Anybody else bleeding badly nearby, this is a triage component to say like that is still your major priority. If there's someone else, go ahead and get them. Again, this was adult male, so we're going to click on that button. Is your patient awake? Yes, they are. Was the patient involved in an accident or did they fall? What we're trying to do is to get information for steps later on in the application to determine should we be moving them around or not. So let's say no. Is the patient having any trouble breathing? No, they are not. All right, so what type of kit are you using right now? We don't want to give you instructions for things you don't have. So that pouch style mobilized kit at the top versus the comprehensive hard pack or backpack at the bottom, we're going to select that one for now, but there are different options here. Are there any other patients with bad bleeding, unconsciousness, or trouble breathing? There are any other patients, but this is again trying to triage for us. And what is the problem with this particular patient? I think this is an injury. All right, is there bleeding from an injury? Well, yes, there was. So we're going to click yes for bleeding from this injury. And now we're going to go into some protocol steps here. So is there bleeding by any one of these? Trapped limb, impaled object, amputation? I don't know what that means. So you click the more info button. An impaled object is something that penetrates the skin and remains in the body. Okay, clear, it's not that. So none of these, we're going to click that button. And then where's the bleeding coming from? Again, we can select that right upper extremity because that's where our bleeding and wound is. And now it's going to give you some steps and it says, okay, go ahead and locate the gauze. Just for point of reference, say the gauze is missing. It's not there. Someone took it to blow their nose. So we have no idea what happened to the gauze, but I don't have that one. So down in the left-hand corner, you can select, I don't have that. And then it gives you the next possible management there that were chosen for your best manageable steps. And it says locate large trauma gauze labeled trauma gauze 2. That's gone. Sorry, don't have it. So locate pressure dressing labeled pressure dressing B3. And again, you're given options here and you have that one. So you say, yes, I have it. Now we're going to open the package up and we're going to expose that white pad. Click the next button. The white pad is going to go directly up against the wound. We're going to hold that pad in place and wrap the bandage snugly around the limb at this point. We're creating a pressure dressing. Secure the bandage to itself. The ones that are in this kit just clip right onto themselves, and it should be tight with pressure around it. So did the bleeding now stop? It did. You did a fantastic job. The bleeding has now stopped from this wound. All right. Whew. It was exciting. Might have been exciting. We tabletop that one, but we walked you through probably the most time-sensitive condition that a lay rescuer could get involved in and make a difference in patient care to save somebody's life. When we talk about major extremity bleeding that are amendable to tourniquet placements, that is an example of a case in which, had we not done that, the outcome maybe would have not been very good. Now, is there still going to be an injury? Yes, there is. The tourniquet itself, by the way, if you've ever been part of that old school analysis of like, once you put a tourniquet on, you've got to take the tourniquet off or release it back and forth so that the limb doesn't have to be cut off. That is nonsense. That has been proven away in studies there. The tourniquet placements that are used commonly in surgical operating rooms every single day can be left on certainly for the time period that a lay rescue or a pre-hospital care provider has placed them on. Once they get to the emergency department, we'll make a call about what to do with it next. But that time frame of certainly less than 60 minutes or 90 minutes is not going to make any difference. You just saved a life. Congratulations. So care past the bleeding control itself, we did that. But now just rather than sit there and stare at the person, is there anything else that maybe we could potentially do? So we'll go back and ask mobilize on the step we left off with. Secure the bandage to itself. That was the last step that we got involved in. And the patient appeared to be bleeding anywhere else. Again, triage thing. Any other wounds? We're going to say no. Is there anything else wrong with the current patient? If you said yes, it would kind of take you back to an intro screen, but there's nothing wrong here. And again, one more time, are there any other patients? We say no. So on the final steps, we say, is there a blanket available? Which there is, emergency blanket number 7. It's certainly important to keep people warm unless they're overheated. And then there's a note here that says, let's not put it on them if they're overheated, but we do want to keep them warm. So we're going to walk into some steps and then how to remove your gloves, because your job is a little bit done. But there's a few other things that I wanted to show you on the screen here. Down at the left-hand corner, there's patient has a new problem, and that would take you back to the beginning. There's also patient is now unconscious. If they went unconscious, there's a few other things we got to look into, because now the airway might be an issue, respiratory concerns, all that stuff. But at the top, there's press when EMS arrives. And that button exists, or when EMS arrives, you get this summary screen. And the summary screen are now timestamps of every single intervention that you just made by clicking on buttons. In this particular case, the tourniquet placement of the first and second tourniquet are timestamps for that provider to know exactly when the tourniquet was placed. That's important. Top right-hand screen, those 3 little dots up there, we can do something with this. So we can click on those dots and it will create a screen for us in which we can now airdrop them. We can text message them. We can send them by Outlook. We can send this information to providers to include in a pre-hospital report, or get that information directly onto the emergency department. So we click next, and now it's just going to walk us through some steps on how to properly remove your gloves, because it's not just pull them off. There's a little sequence that I think it's important to remind people of how to take your gloves off so you don't continue to get any body fluid exposures unnecessarily. And then a process of being able to wash your hands. There are included wipes and those sorts of things, and sanitizers, within the mobilized kits. And from that perspective, you are done. So back to your emergency action plans. I had asked you to, at first, dip into your system and say, where are you at 9:37 in the morning and this injury happens, how are you notified? If that plan in your mind went swimmingly, then congratulations. I think you're probably a little bit in the minority, but in this particular case, you are probably exemplary. And it would be great if we had an opportunity to share those things just for the preparedness sake with everybody else. If you're a little bit gray in the middle, that's okay. We've got some ability to intervene here, but we want to create a system for responders to supplement emergency action plans. And then again, starts from this perspective with this lecture with that lay rescuer involvement. And we get some pictures even to show this as well. You've got somebody that decided to call 911, great. Another person who says, I'm going to get the AED and start doing CPR and compressions of the AED. And then you've got other lay rescuers that are there watching. And I call them lay rescuers. They're not bystanders, because lay rescuers to me are bystanders that were converted over to rescuers in an instantaneous amount of time, as long as we can give them an opportunity to exist by removing some of those barriers that we discussed. So where are we going to do all this stuff? All right, so we need to plan for where people are. If this is houses of worship, this is concerts, this is airports, athletic fields, schools, office building, wherever people are located, and there may be some barrier to treatment because there's a lot of people around. Even in residence, obviously this has the same applicability within a residence, but we're talking about this in an office space or a school space where individuals are located in groups, and perhaps geographically they're set back some distance off of a roadway or multiple roadways. What do we have to prepare for? So wherever these people are, think about the gap again. So the system might work. Make sure that all your pieces of the puzzle are together for identifying the call, the 911 strategy, getting equipment and rescuers to that patient, but understanding that once you hang up that 911 call, there is still an actionable item in many scenarios in which we can do something. I think training is paramount. If that's we're continue to go with training, and that's affordable, and we can continue to do that on a consistent basis, you will be a very safe organization. Understanding though, there is a need to keep up with this. There's a need to evaluate equipment. We'd have to inspect things. Are you doing it on a monthly basis? Is it quarterly? Is it annually? If it's greater than that, it's probably just not a very good system right now. Equipment itself, and reevaluate your equipment. What does your AED look like? Are you aware that there may be a battery life that's on there? There's a little button many times that toggle between greens and reds and X's that will tell you if it needs services. Is this part of somebody's job to make sure we're inspecting that and make sure your equipment is in the right spot? I am not a believer of, and I understand the security of them, but I'm not a big believer of we have expensive training or expensive equipment to respond to rescuers, and it's always behind somebody's locked door. That's a little useless to me. I'd like this to be in a little more of a conspicuous spot there. Why? Because if it's a door where everybody accesses and your AED is always out there, how many hundreds of people have walked by that AED and noticed it? Probably a lot more than you think. So when you call, can you go get the AED? Can you go get the mobilizing? Can you go get the trauma kit, whatever it might be? A lot of people will know where that is, just like they'll know where fire extinguishers are. They're supposed to be conspicuous. Communication. Again, we talked about this before at 9:37 a.m. How are you activating the team? Is there a system of how to get your responders to the scene to do the job they need to do? The knowledge portion of this is huge. Knowledge about what systems are and what you have in place. Again, if they're behind locked doors or you have some secret squirrel meeting that comes back together a couple of months, it's only a couple of select individuals, and we're not pumping that out to the masses, then perhaps your really great plan isn't even recognized by the other individuals who work in the same setting as you do. Your preparation of this is this. We're talking about preparation right now. Your preparation is that you care enough where you're sitting through this webinar listening to me to talk about how can you be better prepared and what are the systems and the tools you can put into place. After that, schedule a meeting. Get your team together. If it's been a little while, no fault, right? Just get the team back together. It's totally okay. Water under the bridge, but let's continue to move forward with being prepared. Empowerment is the spin on what mobilized rescue systems can do for you. It's empowering your lay rescuers and your performers in your emergency action plan to be able to actually do the job that you'd like them to do. In a perfect world, we don't have any injuries or illnesses. And in a realistic world, we have to be prepared for them because it's really not the if, it is the when. And when it happens, we certainly want to make sure that we put our best foot forward with that. Do you have the right equipment for the job? All right, again, here's your strategies. Bleeding management, cardiac and respiratory emergencies, unconscious people. People pass out all the time for any reason. If you work in a high school, 17-year-olds pass out more commonly than anybody else. I have absolutely no idea why. They get hot, they get bothered, they don't eat breakfast, they drink lattes where they should drink waters. Kids pass out, adults pass out too. Many times it's a little more of an issue when it's an adult versus a child, but unconscious person is a very, very common emergency. A major trauma, some burns that might exist. Overdoses have been part of mainstream, and I think that if you're not using a naloxone access program, and I can't speak for every community there, but I think most states have deregulated this to the point where overdoses and naloxone for opiate emergencies, regardless of how you feel about that, the medicine is still that we prefer to not have people die. So being prepared to deliver naloxone in cases of emergency for those overdose cases is a form of using lay rescuers for a really important role. And then other medical emergencies that might exist. Do you have the right equipment to deal with this stuff? If you don't, my question to you is to reevaluate that just a little bit. So you're a responder. Here's your homework assignment. Sorry to the teachers on here, I get to give you the homework today. Your homework assignment is to, if you have been involved in an emergency, or if you have called 911 or heard of 911, I want you to use that same example. Just like I gave you, and if you don't have one and you can't think of one, it's fine. Use a 57-year-old male or 54-year-old male that was a maintenance worker that had a mirror lacerate his arm. That's okay. You can steal mine. Put yourself into that frame. Again, if you have one that has something in your mind, you're going to jar some emotions that go along with it. And I think that's an important tool to be able to motivate a lot of individuals. Your homework assignment is to take that scenario, look at your emergency plans, look at your equipment, and ask yourself, can we manage that? Did we do enough job to fortify our team and our system? Do we have the plan? Do we have the communications? Do we have the gear? Can we assess people? Can we deploy appropriate time-sensitive medical care using good technology, using all of the available responders? Now, is there a system in place that's going to withhold, I'm sorry, uphold to the idea that you are able to satisfy the common medical emergencies that exist wherever you are? Right? So that's your homework assignment. Even if you want to make this a mental exercise, but perhaps use this as a tabletop the next time your EAP team gets together, or next time you're talking with an administrator saying, I was thinking of this. If this happened over there in this location, I don't know we will respond to it, or we did a really great job because we just called 911 last month under this scenario. Our team got together. I think kudos are important as well, but the evaluation of this plan and be critical about yourself, because there's really no reason that you have to sit around patting each other on the back necessarily if your plan isn't going to withstand the test anyhow. All right, so just be critical about it so that we can end up doing the right things for the right patients. With that, I will open it back up to Ryan here. Let's talk. What kind of questions do we have?
Thank you, Dr. Bart. That was a great presentation. Lots of good information in there. As we mentioned at the first of the program, we are going to be giving away a couple of the Mobilize Interactive Trauma Compact Kits to people who are logged in and listening live. And we have taken a random drawing as Dr. Bart was giving his presentation. The first winner for the Mobilize Compact Kit is Teresa from right here in Illinois. And our second lucky winner is Vicky from the great state of New York. So Teresa and Vicky, congratulations. We'll be reaching out to you to get your information as far as sending these kits over to you. We do have a number of questions that have come in during the presentation, so we'll jump over to those now. First, I want to cover just a couple of nuts and bolts questions that have come in. Lucy, Kelly, and Annabelle have asked about receiving copies of the recording or the slides, and yes, we will be sending out a copy of the recording today, about 2 hours or so probably from now, and a copy of the presentation slides will also be attached onto that email. So just keep an eye out for an email from School Health with that information for you. I have a question here, and this is an interesting comment more really, Dr. Bart, that ties into what you were saying, but Michelle is talking about how she is a school nurse where it takes 40 minutes for 911 emergency services to respond. So that, I think, ties in very well to the message that you were giving. I don't know if you'd like to comment on that other than just to kind of recognize that that is a situation that many people are in.
Yeah, I think both, Ryan and Michelle, thank you for being brave enough to say that. I think that there are probably a lot of our attendants today that can constructively look at this and say, yeah, it takes a significant amount of time for emergency services to deploy. In some of those situations, in many townships, they'll also use police because there's usually more police cars that are available. But even the limitations of that of saying, we're going to send police, if they have formalized training, then terrific. But in most situations where I've been part of this, the police that are responding are essentially doing the job that I've tried to demonstrate to you today. That lay rescuers being involved in the system. And just think about that. You are the school nurse, and now, but you're charged with the health of everybody. It's the students, okay, understandably, but is it the parents, the visitors, the administrators, all of the other teachers? Anytime anything happens on whatever school campus you are, who are they calling? They're going to call down to the nurse's office first or radio someone there. So I think that's where this emergency action plan is going to start. But who else is there to help you? What kind of equipment and gear and training do they have? I think that's a great comment. And again, thank you for bringing it to us.
Absolutely. Thank you, Michelle, and thank you, Dr. Bart, for your feedback on that. I've got a question here from Candace who is asking, once you use an item from the kit, can you order replacements of only the item that you use, or do you have to purchase an entirely new kit? And I can say that we do have replacement items available for the kits. It is not necessary to buy a full new kit if you use, one or two items from the kit. Dr. Bart, a question for you here regarding tourniquets. Patricia is asking, what kind of tourniquet should we have in our go bag? Also, what kind of dressing is most important to be able to manage heavy bleeding?
I think it's a great question. I will answer generically about tourniquets as well, is because we get this question all the time. The major contributors, the one that we were showing there, the soft TY tourniquet, and then there's the CAT tourniquet, CAT. Those are the most common ones on the market, but there are other tourniquets that are available. There's not one that's better than the other. The answer to that is use the one that you have, use the one you're familiar with, and please use the one that you practice and put your hands on before, so you understand the mechanics of that. Essentially, they're all belts that have some sort of rod or device that twist. That what is it actually doing? So what does the tourniquet do for you in the first place? It's taking the blood vessel and squeezing it against the bone. What else does that? Blood pressure cuffs do that. And I'm not saying a blood pressure cuff is a replacement for a tourniquet, but if you've ever taken anybody's blood pressure, the first thing you do is crank the thing up to force all the blood to be pushed away from the arteries against the bone, and then you release it so that you can get the numbers of the systolic and diastolic. The tourniquet itself, the commercially available ones that are there, I don't recommend that you make your own tourniquets. Belts fail. Ropes and things as ligatures just create damage and don't work really well. I know there are some bands out there that have marketed as well. Personally, it's not my go-to because I think what's nice about those is they roll up and they compact and they can seemingly go in people's blowout kits that they can carry around with them, and that seems like that's the answer to the problem. But I've found that they're cumbersome. They fall on the ground. They kind of pill up. So I think between the soft TY tourniquet and the CAT tourniquet would be my preferences on tourniquet placement. One other quick thing about this, Mobilized said, bring it far up on the extremity, all right? And if you're a medical trained professional, you say, but is that necessary? Can't we just put it a couple inches above the wound? The answer is yes. So both scenarios, the answer is yes. In untrained rescuers, again, the instructions are for lay rescuers. We don't want to miss any potentials of other injuries or something that's a smaller bleeding wound. So we're saying if you're going to put a tourniquet on, put it up as high on the limb as possible so you don't have to worry about secondary injuries and which other tourniquets are required. As far as equipment for bleeding control, you can make this even simple. You can take an ABD pad or something, a large piece of gauze, put that with pressure. I think pressure dressings are the best, and you can get an ACE wrap to go along with that. Trauma gauze that exists. There are different types of trauma gauze that you can get that is kind of like hemostatic agents that allow basically blood to clot within the gauze themselves. For large gaping wounds, that might be helpful as well. But I think at its basis of having a tourniquet and then having like an ABD or larger trauma pad dressing, and then something that wraps around that creates some pressure of it. If you look for that style of dressing, regardless of the manufacturer of that, I think you're going to get what you need out of it.
Wonderful. Great information. Thank you, Dr. Bart. I've got a question from Wendy here, who is a school nurse, and it sounds like Wendy is in a position where with her school or within her district, having kits, everywhere that they could possibly be is not a financial option that they have. And so Wendy is asking how you prioritize where kits should be. And it's not necessarily just kits, but how do you plan to put your equipment in places that you will need? And she's thinking specifically of scenarios where you might be in a lockdown situation and she can't get to the student or the student can't get to her.
Yeah, and the lockdown scenario is that wrinkle. And again, we can solve that by, I know it's an easier thing for me to say than it is to do, that are finances really the concern if that's the case? And I guess that's my challenge to the administrators of, I know that there's only a certain amount of dollars to do things, but we just left in May and Stop the Bleeding Month, in which the whole campaign around the entire country is to make sure we've got the right equipment to do the job. When lockdown drills and lockdowns themselves are particularly challenging because, like you said, if they're not in the exact room, then where are they? I would say at very least, if you want to strategize this thing, make your emergency stuff in one location. So generally we want to say AEDs should be about a 3-minute walking distance back and forth to where a patient is. So when you plot them around where your campus is, we want to ensure that there is enough time for somebody to go get one and bring it back. If you have one and you've got 100,000 square feet that you need to cover, you may not be having enough equipment there. If you're going to take hemorrhage control equipment, regardless of that, or a mobilized kit or a station where you put it all together, I think your best strategy in those scenarios is to try to make sure it's all in the same place. So if you're going to have an AED and a fire extinguisher and something like a mobilized kit or likewise, I would suggest you keep those all in the same place. That would be my minimum recommendation.
Okay, and then we have a similar question, and to follow up, Dr. Bart, um, Wendy's concern, it was related to a financial concern. The school or the district just did not have the finances to have them in every location.
Yeah, no
We have
doubt. I think Ryan, I'm sorry to interrupt. I think that is a very, very common scenario of, yeah, we would like to put these types of kits or equipment or AEDs in every conceivable corner, but it's not realistic. There are financial limitations that exist there. But I would say that there are different platforms of this. Particularly, we just talked about the Mobilize. We gave away a couple of a small pouch kits. They're not thousands of dollars each. So how do you suggest that when you build a budget? Perhaps we talk about, we'll get a few of those this year, then we'll build it in for next year, and then next year after that. And then you make it a continuous cycle of things that are discussed as part of your emergency planning.
Absolutely. We have a similar comment from Mary Beth, who asks specifically about tourniquets. She has 8 buildings, and she wonders if there is a rule of thumb for how many tourniquets, for example, you might recommend for a building.
Not necessarily for the building itself, but with the perspective of how many people do you have that come onto the campus, I think we can identify that, like, certainly having one kit. If you were going to have one centralized kit, my recommendation is that you have 4 tourniquets in that kit. For every satellite, we'll say, of equipment that's in there, and every building should be its own thing, unless your buildings are all tied together by hallways in which things are accessible. But if you got to go outside and then enter another building through another door, I would consider that a different space. It's part of your initial emergency action plan, but in an ideal circumstance, every building would have its own separate AED or medical kit. If you have a centralized kit that had 4 tourniquets in it, then I would say if you're going to put a few other ones around in your building, then look for smaller kits that maybe have 2 in there. Just in the circumstance that we had to use 2 on one patient, or if you had 2 patients that needed 1 each, we're going to exhaust that pretty quickly, but we know that more help is on the way.
Wonderful, thank you. Question from Annabelle, and we're switching gears here a little bit to, I think, how the app moves through different scenarios. And we talked specifically, or you talked, Dr. Bart, about fainting or unconsciousness. Can you talk a little bit about what might be contained in a kit that helps address unconsciousness? And I know that there could be a number of different reasons here, or how you might identify what reason someone becomes unconscious and how you can move forward from there.
Yeah, no, I think it's a fabulous question. When we talk about unconsciousness, we have to identify, again, the time-sensitive priorities that exist. Just like we talked about, bleeding management is that first step. If your patient were unconscious, we have to first make sure, do they have an airway? Are they breathing? So I think when we talk about unconsciousness, it's first airway, breathing, circulation, like we've been trained with our ABCs for CPR. If their airway's open, and then they are actually breathing, but they're simply not conscious, we've got to think about the other things that exist. So overdose is one of those that we briefly mentioned, and Mobilize, because it was questioned here, it has a particular sequence of questions that helps to identify the unconscious overdose patient and then provide steps on how to use naloxone. Now, there's a couple of varieties of naloxone that exist out there. So Mobilize includes both of them, and you click on which one you have for a reminder of what those steps are. Other scenarios that might exist that we could potentially intervene on are diabetic emergencies. And in particular, somebody that's hypoglycemic, now not totally unconscious, because you may ask yourself, like, well, we're not going to stick a tube of oral glucose into somebody who's unconscious. We're going to create a choking hazard. You're absolutely right. So Mobilize takes that into account when it's asking about level of consciousness. And if the patient's not able to take something in their mouth, it skips over those steps. But again, that's the user interfacing here, that the user says, I'm going to tell you what I have. And Mobilize says, all right, I'm going to tell you what I think you should do next. If somebody's just simply passed out, then we're going to identify for trauma. We're going to put them in either position of comfort or in a left lateral recumbent position. We're going to keep them warm under those situations in which their heart's beating normally and they're breathing, and we've activated 911 and there's no major bleeding or nothing else to take care of. Then the only other option we have is to wait for the ambulance to arrive. But we've gone through all the scenarios to identify that there is no time-sensitive condition in which you're missing that you would have had to intervene on.
Okay, wonderful. Thank you. Question from Kirsten talking about pediatric tourniquets. Can you comment a little bit on the difference between pediatric and adult tourniquets and how someone in the moment might make a decision of which to use if both are available?
Yeah, and the idea of pediatric tourniquets is it's just a size thing. So when a pediatric tourniquet exists out there, and it's not as a common of a scenario, because most tourniquets themselves can accommodate the size of an arm. They get all the way down to a very tight. If we're talking about an infant, then perhaps you can't get the belt to get that tight. But again, the tourniquet's job is to take the blood vessel and squeeze it up against the bone. In the scenario base, the difference between using a pediatric or adult tourniquet is going to have to be subjective on certainly what you have that's available. Mobilize has tourniquets for the adolescent and the adult patient necessarily. There's not a specific tourniquet that's for the pediatric patient. Again, I think if that's available and it just seems like it doesn't fit, and there's a pediatric tourniquet, from a size perspective that's available, then just making that subjective determination. But for the most part, the tourniquets even that are intended for adults, they're very long, but they can get very small as well.
Okay, great information. Thank you. It looks like we are getting short on time here, so I will go ahead and stop here for the day. If you have submitted a question and we haven't been able to get to it, please know that we will reach out to you with a response to your question. I'm just being mindful of time here out of respect for everyone who has logged in. So I'd like to thank everybody for attending today's webinar. I hope that you found the information useful, and thank you again, Dr. Bart, and to our friends at Zoll Medical for helping to bring today's presentation to us. As you exit the webinar, you will see a survey window. We would ask each of you to take a brief moment to complete the survey and let us know if you like what we've done here today, if there's something that you would have preferred to see that you weren't able to see, or if you just have any general feedback for us. We would appreciate that so that we can help to make these presentations better as time goes by. So thank you again, everyone. Thank you, Dr. Bart, and have a wonderful afternoon.